welcome to all of you for this third edition of our Spotlight series season 2 on SRHR, Sexual and Reproductive Health and Rights. We had the first set of webinars on cervical cancer and HPV in April, and this month, June onwards, we bring to you a 3-part series on infertility. We start today's webinar, part 1 in the series, about addressing the female factor of infertility.
Good afternoon, everybody. Today I'm going to discuss the general aspects of infertility and what we can do in our clinics, in FPAI clinics. As we all know, infertility is a serious and alarming health issue with ramifications both for social and physical well-being. And as you know, in India, parenthood has got a high priority and it's a highly emphasized and a vital event for couples in every society in India. And infertile couples experience a sense of failure and exclusion and isolation because of the expectations of the society, the family, faith, and culture. The prevalence of infertility in India to be between 3.9 and 16.8%. That's a very large, wide range of incidence because it all depends upon the geographical area, it depends upon the social strata from which the women come, it depends upon the age incidence where the woman comes. So it's highly variable. And the prevalence of infertility in India during 2019 and 20, where the NFHS 5 gave its data as 18.7 per 1,000 among women who have been married for at least 5 years and who are currently in union. So that's about 1.8%. So there is a wide range of incidents. Infertility is defined as failure to conceive after 12 or more months of regular unprotected sexual intercourse. And we also know that infertility is steadily increasing due to the delayed childbearing and rising rates of male infertility. Studies have shown that infertility causes anxiety in 23.2% of the women and depression in 17% of the women who are unable to conceive. So that is why they require a lot of counseling. What is important is that every woman who's planning for pregnancy should be taking folic acid supplementation. Assessment and basic investigations for infertility. What is important is couples with fertility concerns should be interviewed separately as well as together, because it's very important to take the history of these people. A detailed history is very important. The women whom we will refer to the specialists are women who are aged less than 30 years, who are unable to conceive after regular unprotected intercourse for 2 years without any known reproductive pathology, or women aged more than 30 years who are unable to conceive after regular protected intercourse for 1 year without any known reproductive pathology, or patients with a known history of reproductive pathology. A word about PCOS, because we see a lot of PCOS these days, lots of young girls, not only infertility patients, but young girls who are overweight, who have acne, who have hirsutism, who have irregular cycles. It's very important that we guide these girls at the adolescent age itself, counsel them about lifestyle modification, counsel them about exercise, diet, and see that they don't progress further and become put on more weight and lead to more of insulin resistance. So it's very important to take care of these adolescent PCOS before they become worse. For those women who are planning for pregnancy, it's very important to counsel them regarding their body weight and lifestyle modifications, including avoiding smoking and alcohol and the benefits of exercise and a healthy diet.
So I'll be talking about the female partner today and what is the evaluation that we can do on history taken and examination. So we have to know the age. Previously, the paternal age was never taken into account, but now we know that paternal age is an important factor in considering infertility. Occupation is a very important parameter that we need to know. If the wife is working very often, so it is important for us to know the occupation. And education is important so that we know how much they will understand and at what level we need to talk to them. The cohabitation period, the use of contraception is important. Menstrual history is the same or it has changed over a period of time. and then how many days the flow is for, whether the flow is normal, whether it's associated with any abdominal pain. The family history for infertility amongst the brothers and sisters. Sometimes they come with the history that they feel that there has to be a simultaneous orgasm between husband and wife to achieve a pregnancy, which we have to correct by counseling. We can come to a provisional diagnosis from the history and from the examination findings. So we don't put the patient on a list of investigations which are not necessary. If we evaluate correctly on history and examination, tubal factor affects almost 25 to 30% of couples who present to us with infertility. So this is showing you a diagram of the fallopian tube. If there is a blockage in any of these portions of the tube, they can be handled surgically or medically or by alternative method. The first method of assessment of the tube is hysterosalpingography. On HSG, what you find, and then whether to proceed further with treatment surgically or else by advanced techniques. The other method is by doing a laparoscopic evaluation. Preventive management is the most fruitful that we should do, and we should all encourage patients, the couple, to use condom, because it prevents not only pregnancy, but it helps to prevent sexually transmitted diseases, which patients may not be aware of also, and it can lead to tubal infertility, tubal factor infertility. Now we'll talk about the three regions of the tube: the proximal, the mid portion, and the distal portion of the tube. So in proximal tubal occlusion, surgical management can be done by different methods. One is fallopian tube recanalization. Second is microsurgical tubal corneal anastomosis. And the third is corneal implantation. They are all used in different conditions of the tube. Okay, so in fallopian tube recanalization, you either use a wire or a catheter, or you use a catheter through which you pass a wire and then you pass it into the tube. Now, that alternative management, what we can offer to them is IVF-ET, and it has brought about a sea change in the scenario of tubal factor and term pregnancy rates for late afflicted by blocked tubes which are inoperable.
I'm going to be talking about the endocrinal and the non-structural causes of female infertility. Before we understand the causes, we must very clearly understand that infertility is a disease of the couple. It's a disease of the male and female reproductive system, rather the reproductive machinery, and is defined by the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. As I said, I would be talking on the endocrinological causes of female infertility. The female infertility is directly related to the hormonal interplay in the HPO axis, that is the hypothalamico-pituitary ovarian axis in women. Normally, this runs in synchrony and leads to important events such as ovulation, endometrial ripening, etc. However, imbalances in the hormones can affect reproductive function. What we need to understand is that infertility is a major association with PCOS, because in PCOS, because of the endocrinological dysfunction, the ovaries do not ovulate at all, leading to anovulatory cycles. How does this impact fertility? As there is an hormonal imbalance of the female sex hormones because of inappropriate and untimed release from the hypothalamico-pituitary axis, there results in improper development of the oocyte and improper ovulation or release of the oocytes. So both, it affects the growth and the ovulation. Now, when this occurs, this doesn't occur, rather ovulation doesn't occur, it would not result in pregnancy, and therefore infertility occurs. It also causes an increase in the production of testosterone. The next endocrinological problem is the thyroid dysfunction. There are two types of thyroid disorders: hypothyroidism, as the name suggests, when there is less amount of TSH to meet your body's needs, and hyperthyroidism, when there is more thyroid TSH, or when the thyroid gland synthesizes more thyroid hormones. Both of these, hypo or hyper, affect fertility but hypothyroidism is being seen more and more in women of reproductive age. The thyroid axis and the reproductive axis have a subtle interplay. So therefore, affection of one affects the other. The next important hormone is prolactin. And prolactin is basically the hormone of lactation. And therefore, in a non-lactating state, if it is excessively released, it means that there is something pathological. So we've started from the ovary where I discussed PCOD. Then we went on to the pituitary where I talked about the prolactinomas. And now we move on to the higher center, that is the hypothalamus. Hypothalamic dysfunction is associated with hypothalamic amenorrhea, and this occurs secondary to decreased or inhibited GnRH secretion, which affects pulsatile release of the pituitary gonadotropins, and this diminishes the quality of eggs, and if present tonically, that is persistently, causes an ovulation. Now I move on to the next endocrinological problem associated with infertility, and that is luteal phase deficiency. The main role of the corpus luteum is to support the early pregnancy by production of estrogen. And therefore, if there is a deficiency of this, which is called as LPD, it is associated with insufficient progesterone exposure to maintain a normal secretory endometrium and allow for the normal embryo implantation. Lack of progesterone has been associated with infertility and also, more importantly, early pregnancy loss. What I mean by non-structural is that it means factors that are not related to physical abnormalities, namely age-related infertility, lifestyle factors, immune system disorders, and finally, unexplained infertility. The fertility potential of the woman declines as age advances. And therefore, a woman's peak reproductive years are said to be between the late teens and the late 20s. And by the age of 30, the fertility begins to decline. A good balanced diet, including one which has proteins, vitamins, carbohydrates, important minerals which have been directly related to both male and female infertility are zinc and selenium, calcium, vitamin D, which acts at the level of the ovary, has shown great promise in research studies in PCOS and omega-3 fatty acids. DHEA is also known to play an important role in women with poor ovarian reserve or premature ovarian failure. So, a diet having all these micronutrients with the adequate amounts of proteins and carbohydrates and fats will play a very important role from the fertility point of view. The next is to keep your body active, and that could be by exercise. Daily walks, cardio, Zumba, yoga, meditation, swimming are various strategies which help both physical and also now well known is mental well-being, which helps to maintain the fertility by good stress. Irrespective of the type, it causes a release in cortisol levels which are abnormal, and this leads to hormonal imbalance. Mindfulness by means of yoga and meditation is advised to deal with the stress. Environmental and occupational exposure can interfere with hormonal balance and disrupt ovulation and impair sperm quality. Substance and drug abuse and smoking and alcohol, all these addictions can have and do have a significant effect on infertility. Autoimmune systems disorders like diabetes, thyroid disease, SLE, all of them cause an environment which reduces fertility by affecting sperm and egg quality. Last but not the least is unexplained infertility. Well, to put it simply, when there is infertility and we don't have an explanation for that. In other words, there is no identifiable cause despite a thorough evaluation. It affects importantly about 10 to 20% of women. So 1 to 2 couples will have unexplained infertility, and the treatment includes using fertility medication, lifestyle change, and using IUI and IVF. Genetic testing of both husband and wife are important where you want to rule out a genetic or a karyotype related cause for infertility.
One question that even I kind of keep thinking and asking. At which point ART should be considered if you are treating the woman for infertility, and should we continue to treat her? After what point of time we can consider ART to help her if the treatment doesn't seem to be working out? So over to you, Dr. Nandita.
I think it's very important to understand when you have to switch to ART, that is assisted reproductive technology or IVF. Remember now, there are certain indications where you have to do it. You cannot try other things like severe male factor if your count is below 5 million per ml, or if your tubes are blocked and you've done tuboplasty and she's not conceiving within 6 months, or you're unable to do the tuboplasty. Sometimes you just cannot. Then because of tuberculosis, the tubes are blocked, you cannot open them, then the success rate is low. It's better to switch over straight to IVF. Another indication which is very common is unexplained infertility, PCOS, endometriosis. See, all these patients, we try simple treatment like IUI, intrauterine insemination. If it doesn't work, then say if the girl is under 35 years of age, I try 3 or 4 IUI cycles. If the girl is above 35 years of age, 1 or 2 cycles. If they don't succeed, it's better to switch over to IVF.
Do you think the microsurgery or the tubal surgery reversal is now redundant, and we should straight away now, because the technology is there, we should straight away go for ART, or we should try first the tubal surgery? What would be your take?
I mean, as a IVF specialist, I think age of the woman is very important. The AMH, and if she's young and good AMH, I would do tubal surgery, because what happens is tubal surgery gives us a chance of natural pregnancy, and especially reversal of tubectomy is a very successful process. Problem comes when there is infective pathology, and because of that the tubal block is there, then even the tube may get damaged. So yes, we do have a procedure called philoscopy, where we actually put in the telescope into the tube to see if the tube is not damaged. So I think you should not jump. But at the same time, today IVF has such good success rates that if you're not good at microsurgery, see, I think we should not spoil the chances of the patient. So if you're very good at microsurgery, or you're getting it done from the best of people, young patient, good AMH, I think it works very well. And especially fertile patients, tuboplasty done. I mean, tubectomy done, and you're doing a reversal. I think it's very good.
Do you recommend a gap after ovarian stimulation, 3, 4, 5 cycles? You have given clomiphene or any other stimulant, and then you are trying to do that. Is there a gap needed, a rest period, and then you try again, or what would be the period for which you could continue to give ovarian stimulation for a good ovulation?
You can do as many cycles as you want, and also it doesn't matter. You don't need a gap. In fact, when we do IVF, we prefer back-to-back cycles, because the ovary is stimulated by our injections, by our drugs. So it's the ovary, especially in poor ovarian reserve patients, it behaves well if you do back-to-back cycles. Back-to-back cycles is a good idea, and it does not matter. But I feel the emotional well-being of the patient is very important. Sometimes after a negative cycle, patient is not mentally ready. So I always tell my patients that if you're mentally ready to go ahead with the cycle, let's do it.
What is the impact for on infertility of repeat abortions? Suppose if a woman undergoes abortions 3, 4, 5 times, what is the impact of repeat abortions on secondary infertility? Does it lead to? And a related question, which also comes from the field, that
The male factor is one of the things that needs to be evaluated very closely in repeated pregnancy losses, because there may be DNA. Now we know that DNA fragmentation index can be high in patients who have couples who have repeated pregnancy losses.
Well, the only reason she can have secondary infertility is because of infections. So if a safe abortion is done, probably they will not become infertile. And the more repeated MTPs happen, the more chances that she can get infected and tubal block can happen.
So if you have any infection post MTP, so giving antibiotics, doing it in a aseptic area, sterile instruments, everything is so very important. Third, the third point, which is very important for an abortion case, is repeated abortion can cause Asherman's. Endometrium gets damaged. So you have to be very careful that, nowadays a lot of people, if it's a second or a third time you're doing an abortion, do it with ultrasound. I know it's not that easy. You are very blind one, but you could do it with ultrasound so that you don't overcure it.
Technically, per se, MTP will not result in infertility, but if it is not done well, then it can end with complications which may be silent and the woman may not know.
First trimester abortions have a higher percentage of genetic, karyotype or genetic abnormalities. So those in the second trimester abortions mostly have some structural things, which can be the structural defects in the uterus, which can be responsible for it. But of course, we should evaluate all of them. And as I mentioned, it can male factor also can be, and we know that paternal age is another important factor which can lead to not only infertility but repeated pregnancy loss also. So that has to be kept in mind.
There is a technology which empowers women. When the oral contraceptive pill came and the abortion, it's a women empowering technology.
Yeah.
Where in fertility also, egg freezing is very, very women empowering, because you don't have the fear of the biological clock. So even if you're getting older, you've not found a partner, or due to whatever reasons you're busy with your career, I think you can freeze your fertility rather than marrying any guy who just comes along because you want to have a child and your time is running out. So I think that is there. Cancer patients can preserve their fertility, because cancers are curable today, especially young girls. We treat a lot of young girls with breast cancers, and they come for fertility preservation and they get cured and they have babies later on. They get married, have babies.
Thank you, Nandita. And that reminds me also one more kind of group of people who we see a lot, and that is transmasculine people who really are deciding yet whether to and how to become parents and how to conceive or to kind of use their ovums. How so they are still figuring out their lives and their sexual partners and their life partners. And we've seen a few and more transmasculine people, even within lesbian partnerships. We have seen women who are thinking about those choices. And I think this is a very, very important technological advance that they should have access to. All people, individuals who want access to have children.
It is time to be fully informed about the success rates of the various operation techniques, the various operators, the surgeons, and the centers which are doing the surgery, so that you can refer to the center which you feel is giving the best results.
Kalpana, I would talk from the point of view of our centers, our clinics, our FPAI clinics, where we are doing only the basic work. I would stress that it is extremely important to take a thorough history and a thorough clinical examination, and also important that you interview the couple separately and together, both, so that there are some facts which they would not reveal in front of their partner. So that's important. And also it's important that we rule out certain medical disorders, which we can do in our centers, rule out diabetes, rule out hypothyroidism. And the counseling, most important, is where we counsel our clients, because they are much closer to the doctors whom they have been seeing for so many years rather than their infertility specialists.